Good morning. Thank you, Dr. Muhammad, and thank you, everyone. I'm honored to be among you today. Our first case is a case of Mrs. R. Mrs. R is a
Fadwa,
47.
you have 5 minutes to introduce your case.
Yes, okay,
Okay.
less than 5 minutes. This is a case of 47-year-old female patient who was diagnosed with ulcerative colitis in 2014 and had erythema nodosum in 2014 as an extra-intestinal manifestation of her disease. There was no other significant past medical history, nor any history of abortions or thrombophilia. And she assumed a relatively stable clinical course. She only needed 2 short courses of steroid therapy over the past 8 years. And she was maintained on 5 ASA at a dose of 4 grams per day with azathioprine at a weight-based dose of 2.5 milligram per kg. But then she came to our clinic complaining of 5-day history of 3 to 4 bowel motions per day. There was blood and there was these joint pains in her wrists, ankle, and knee joints. In addition to this, she had a mosaic of an extra-intestinal manifestation of the disease in the form of multiple erythema nodosum affecting her both lower limbs, pyoderma gangrenosum affecting both her lower limbs and upper limbs and also her back, joint effusion affecting her wrists, her knee joint, and her ankle joint, in addition to ischemia in her fingers and her toes. Her labs showed the good CBC picture. Her CRP was though 63.3, a calprotectin level of 581, a negative D-dimer, and a normal Doppler arterial and venous system of both her upper and lower limbs. We do know that IBD is a hypercoagulable state. However, when we think of this hypercoagulability, we assume it is more related to DVT. There is no system exempt from the hypercoagulability that can be a manifestation of IBD, and skin is also one of the organs that can be affected by the disease. We gave her 5 days of steroid therapy of IV dexamethasone at 8 milligrams per day. She showed some clinical improvement in terms of her colonic symptoms and some relative improvement also in her pyoderma gangrenosum. However, her CRP kept rising to reach 145. And at this point, we were thinking that biological therapy would be the best option, and not any biological therapy, specifically Infleximab at an accelerated dosing. We do know that Infleximab works in pyoderma gangrenosum. We've known this for more than 10 years. However, in erythema nodosum, the evidence is somehow mixed. Some incriminate Infleximab with the development of erythema nodosum in some of the patients. Others report good response to Infleximab therapy in patients with IBD. We started the patient on Infleximab at a dose of 5 milligrams per kg, and we gave her 2 doses 1 week apart. And these were the pictures in her follow-up visit, which, as you note, had some improvement in pyoderma gangrenosum, but also subjective and objective improvement in the ischemia that was found in her fingers before. Our take-home message is IBD is a hypercoagulable state. Hypercoagulability isn't just DVT. We have to keep an open mind because there is a wide spectrum of cutaneous manifestations of IBD. Cutaneous manifestations could be a red flag to escalate your therapy. Thank you.
شكرا دكتورة فدوى. بس السؤال يعني دكتورة فدوى, you mentioned this is hypercoagulable states in an IBD. Is it wise to keep these patients on oral anticoagulant?
Actually, her doctors were free. We were not keen on starting anticoagulation since there was no signs of DVT, but it maybe was. I can say for sure.